I want to turn this again upside down. We've been talking about what physicians can do and how we can make patients more aware of what's going on. But what is the level of awareness here among patients with diabetes as to the risk of eye-related disease? We're in the era of the internet. They can put diabetes into Google, and they can come back with your eyes are at risk. Is there a difference between older and younger patients in this?
Well, I think the biggest difference is socioeconomic.
Is that right?
Yeah, we know that young patients are not good. They're not good at getting their eyes examined. They're not good at following through on their follow-up examinations and things such as that.
It's these kids, huh?
And the Medicare patient population is much, much better at getting their eyes examined and following through on things. So I think that, Google only works if you have access to the internet. And so I think that that's where we really need to work is on our lower socioeconomic class of patients to get them seen and treated.
What about older patients? Are you implying that they have a better sense of where their eyes are?
That or possibly they have better insurance, they have Medicare, they have other comorbidities such as cataracts or age-related macular degeneration that actually lead them to knowing when they need to go see the doctor.
So what you're suggesting is as you get older, you get a little bit sicker, somehow or other you get to see a doctor, and once in, then you're part of the system.
More involved, more involved with your health care.
There's been lots of studies that have been done on this, and the one I always talk about is the one that was done at the Joslin, which showed basically if patients who had retinopathy, if you asked them, what did you have? Only 50% of the time they actually told the doctor, I have this. They don't actually understand their disease. I think there needs to be a lot around patient-centered education. I think that spans, both the socioeconomic issues, but also the age issues. It's not a young age or an old age issue. It's more of an educational issue.
And just that issue of health literacy and health numeracy. So we say, and I think this represents a bit of a bias, that it's the lower socioeconomic. We know from research that we've done that there are people that are master's prepared that are also not health literate or health numerate, and so we've got plenty of challenges in front of us to engage those persons so that they understand and appreciate, and they get information that is not a lot of jargon and a lot of medical speak.
I mean, I personally wouldn't care if somebody could say I have diabetic retinopathy, as long as they said my eyes are at risk and I'm going to go see somebody. The actual diagnosis is probably, in my view, I would think, less significant. Right?
But their understanding of what that means and what impact that has is probably quite different. And I think that, again, all of us being physicians here, we have a different aspect of our education level than somebody who's an engineer or who's a finance person on this sort of topic.
But just for the record, how many docs do you know go for an annual exam? The answer is, in my experience, nobody. Nobody. I'll go see John when I get a problem here. And otherwise, I'm a doctor, Jim. I'm not sick, right? And before we leave this, are there specific ways, specific plans that healthcare plans may have to raise awareness of eye-related diabetic problems?
Well, again, we look at those persons with any chronic condition, whether it be chronic obstructive lung disease or diabetes, and diabetes certainly being one of the most prevalent. Then within those populations of diabetics, we're looking for certain key indicators, such as the dilated annual retina exam, such as evaluation of microalbumin in the urine. And so we look at those measures. We make that information available to our clinical partners. We also sometimes do selective outreach, and certain employers actually ask us to, because they're ultimately the ones who are paying the bills, right? The plan sponsors.
Unless you listen to Bernie, in which case it's all going to be single payer.
They say that they want us to do something in addition to what we're already doing to reach out to their persons on behalf of that employer, so that they increase the rates of, for example, dilated exam.
And I was being facetious for a minute. I said, unless you're Bernie and you want a single payer plan, but even in a single payer plan, if you have employees that are losing days of work because of their disability, because of their ophthalmologic issues, it still comes down to the employers, right? There
was a study done last year that showed that the average diabetic patient has something like 20 visits to the offices of clinicians during the year. 20 is a heck of a lot. I only get 4 weeks of vacation, so that's all of my vacation days in a year. So I can imagine that patient trying to make it up and do that the same way. It's a difficult thing to accomplish.
It brings to mind that this balancing act. Where are you going for vacation? Miami? Are you going to Oahu? No, I'm going to the doctor's office, because that's all the time I've got. That doesn't really work, right?
Well, it's hard to expect patients to understand their retinopathy when sometimes they come in and they don't even know their A1C.
Got it.
And that's a scary thing. I'd say probably 25% of our patients don't know what their A1C is. And that's the real fundamental.